Okay. So, dear Dr. Haider, may I introduce a very quick note before we starting?
Sure.
Thank you so much. So, what a lovely night. Thank you so much to be with us tonight, our distinguished colleagues and esteemed guests. Um, this is quite a challenge topic here. Some disorders speak in silence before they ever shout. And among them, bleeding disorders stand as some of the most intricate and humbling. The challenge not only our test, but our very clinical instinct, asking us to look beyond numbers and into a fine balance hemostasis. That around 5 to 10% of hospitalized patients suffer from thrombocytopenia, as well as up to 25% of ICU patients mostly suffer from secondary sepsis, drug-induced causes, or disseminated intravascular coagulopathy, as well as mild transient thrombocytopenia can be seen in up to 10% of healthy individuals, mainly post-viral illnesses or during pregnancy. Me facing this on daily basis. Me as a board trainee oncology this thrombocytopenia occurs in about 20 to 30% of cancer patients receiving myelosuppressive therapy, leading to dose reduction, treatment delays, and up to 50% of affected patients occurs and even occurs in 10% of a pregnancy. So quite challenged, yeah. So we have very privileged here to have a very unique expert to dive us through this hidden complexities, where the missing clotting factor can alter the life, and a simple bruise may unveil a genetic legacy. This is more than a science; it's an art of the screening that I've seen. So we have Dr. Haider Hussein with us tonight, a consultant hematologist at the University Hospital of Birmingham, UK. He was appointed in 2019 as a specialist interest in the myeloid disorders, diagnostic hematology, and the medical education. So our objectives tonight, inshallah, during this lecture is to be able to differentiate between causes of acute and chronic thrombocytopenia using history and examination, and to be able to select appropriate further investigation to identify causes of thrombocytopenia, and to be able to develop appropriate treatment plan for common causes of thrombocytopenia, and to identify an emergency presentations that require immediate management. So our session orientation, inshallah, will be, this is in the timeline here, we have in the end of this lecture, we have, of course, a question and answer part here. So a kindly reminder of a quick note here. There will be a question and answer, of course, in the end of the lecture. To maintain an organized session, we kindly ask all of you, dears, to keep the microphones muted. And if you want to ask any question directly, please just click the right hand icon, and you will be invited to speak to Dr. Haider right away. Alternatively, you may type your question in the chat box, and I will make sure to read all of them, address all of them. So also, do not forget to complete registration, which me and my colleagues will share it shortly in the chat. Thank you so much. And without further ado, let's go directly to Dr. Haider. So, Dr. Haider, the floor is yours. Thank you so much.
Thank you for the kind introduction, and assalamu alaikum. So my name's Haider. I'm a consultant hematologist and I work in Birmingham. And as Qasim said, I work with myeloid disorders, but I also have interest in general hematology. Before I start, can I just ask, can you see the slides and can you see the screen okay?
I can see the slides. I'm not sure about the others.
Thank you. Okay, yeah. Some people are putting in the chat. Yeah.
They are crystal clear here.
Great. So the objectives we've already gone through, but just to say that we're going to go through this in case-based discussions, and I would encourage interaction. So I'll ask some questions. People can put their responses in the chat, or if you put your hand up, if you're feeling brave, we can talk as well and discuss things. So a little bit of back and forth as we go through this. So just some initial thoughts. Just to say, what is thrombocytopenia? So we define it as a platelet count that's below 2.5 centile of the normal range, so less than 150 times 10 to the liter. At that level, you would not expect any symptoms. And in fact, most patients who have a platelet count between 100 and 150, the diagnostic yield is very, very low, and you're not usually going to find something in those patients. When do you start seeing symptoms? Really, I mean, in terms of surgery, if your platelet count is above 50, you can do almost any type of surgery. The only exception to that is ocular surgery or neurosurgery, in which case we have a threshold of 80 to 100. And really, even under those circumstances, there is some flexibility with this. And obviously, the key person who will determine what they're willing to operate at will obviously be the surgeon. You don't tend to see spontaneous bleeding until the platelet count is less than 30, unless the patient happens to be on antiplatelets or anticoagulants. So again, if you see someone with bleeding and the platelets are above that, then you need to think of other factors, particularly things like skin integrity or other clotting factor disorders. And when you come to approaching these patients, it's always important to kind of think of things in the clinical context. Is this an acute process, or is this something that's more long-standing? And if it is acute, how has this changed and how has that evolved? And then from a hematology perspective as well, is this an isolated thrombocytopenia, or are there other abnormalities in the blood count that can point towards a potential cause of this? So we'll start with the first case, and this is a very simple, common query that we receive in hematology. So a patient is asymptomatic, they're 45, and they've requested checkup bloods. In the UK, we call this a Wellman check. And they have a normal hemoglobin, MCV, white cell count, but they're found to have a platelet count of 33. What else will you want to know about this patient who's presented with this blood count? Any suggestions?
Okay, so a little reminder, so you can write the answer in the chat box, or you can raise the icon button, so you can directly talk to Dr. Haider.
So we've got some good suggestions. So the patient is not symptomatic. There's no bleed. And of course, someone with low platelets, any bleeding, specifically mucosal bleeding, which is what you tend to see with thrombocytopenia, no oral mucosal bleeding, no epistaxis, no bruising, and no past medical history in this particular case as well. Medications, absolutely crucial. Drug history, very, very important with thrombocytopenia. And in this case, there's not. And someone has hit the nail on the head. Someone said blood film for aggregates, so platelet clumping. Coagulation profile is an additional test that we'll talk about, and medication. So excellent suggestions, and that really kind of captures a lot of what I wanted to get with this case. So, do they have symptoms relating to bleeding? What is the tempo of that? What medications are they taking? One of the things I specifically look for in thrombocytopenic patients are risk factors for liver disease, because this is one of the commonest causes of thrombocytopenia. And clinically, looking for splenomegaly as well, because splenomegaly causes sequestration and can potentially cause thrombocytopenia as well. I also specifically look for nutrition or malabsorption issues as well, because a very common and easy reversible cause for thrombocytopenia is B12 and folate deficiency. And although that's classically associated with macrocytic anemia or pancytopenia, you can see patients just with isolated thrombocytopenia. But a general principle really for almost any test that you do, whether it's a blood test or a scan or anything, a biopsy, is if a finding is unexpected and it does not match the clinical picture, you should always repeat it, particularly if it's a straightforward test as well. So thrombocytopenia is quite prone to errors. And from a laboratory point of view, we talk about pre-analytical errors, analytical errors, and post-analytical errors. So pre-analytical errors are to do with how you're taking the blood. If a patient has a difficult bleed, so we've all been there where you insert the needle and it just comes out one drop of blood at a time. that causes some coagulation, usually within the actual sample that you have, and that can cause thrombocytopenia to be an artifactual thrombocytopenia. There's another well-described phenomenon, and people have mentioned it a couple of times, is platelet aggregation as well. So what happens is the longer it takes between your phlebotomy and your analysis of your full blood count, if there are antibodies, there are EDTA bound antibodies, which can cause the platelets to clump. Now, the way an analyzer works, essentially you have a flow tube, and each cell passes through that flow tube. And if the platelets are clumped, they get counted as things like red cells or even white cells because they're too big. And so the platelet count is artifactually low. And the way to identify that really is from a blood film. So a blood film will show platelet aggregates. And the way to kind of be sure about it is two things. Is one, that you can always repeat the blood test closer to where the analyzer is. So in the UK, we have primary care. GP will do a blood test. The blood sample will be sent to a hospital. That could happen over several hours, and even potentially more than 24 hours. And then the platelet comes back as low. Then the patient gets referred to hematology. We do a blood count. Because our analyzer is on site, we know instantly that the platelet count is normal. So that's something to be aware of. And it's important, particularly when you're making treatment decisions. Carsten mentioned about chemotherapy. And if you don't want to make a decision about holding chemotherapy when the platelet count is artifactually low. Similarly with surgery as well, you can see operations just being cancelled just because of a simple error. So if a patient, if it doesn't fit the picture, always repeat it. One of the other things you can do is called a citrated platelet count, where you send it in. The UK, we use blue top tubes, which is citrated, and that gets rid of the EDTA mediated artifact. So those are pre-analytical errors. There are analytical errors, which are to do with has your machine been QC'd that day? Is there bias? And post-analytical is to do with how the results are given. Are you sure you've got the right patient's results as well? And these are simple things, but these are always things that it's always good to start from base principles when you first approach a patient. So case 2, in a similar vein, it's an incidental finding, because again, thrombocytopenia is often an incidental finding, particularly when it's in the asymptomatic range. And in this case, we've got a patient who has clinical evidence of chronic liver disease. So they have evidence of spider nevi, they've got splenomegaly, they have possibly they could have ascites. And I'm going to pose a question to you, and again put it in the chat. Why does the liver cause thrombocytopenia? And just to give you an idea, this is a favorite question in the FRC path, which they ask you to say, name the 10 causes of thrombocytopenia in a patient with liver disease. I can see a hand up, Dr. Zaki.
Hello, good evening, doctor. So the first reason, I guess, is because it's going to lower the thrombopoietin level. And the second reason is that it's going to cause a splenomegaly, which will sequester the platelets within the spleen.
Mm-hmm. Yeah, very good. So those are 2 other causes. Any other causes that anyone else can consider? Yes, someone's mentioned clotting factors. I'll just say that this is usually a Viva question in the FRC path, and it always makes people's hearts sink when they say name 10 causes, because you can you start off and then you start running out of ideas. I'll give you a clue, is that a lot of the causes are nothing to do with the fact that they have liver disease or are adjacent to liver disease. Yes, DIC, yes, toxins particularly. So this is my kind of general slide about it. So Dr. Zeki mentioned the liver produces TPO. So TPO is the analogous hormone to EPO, which essentially stimulates megakaryocyte differentiation. So liver disease causes a direct effect on the bone marrow, causing reduced production of platelets. Also mentioned by several of you is portal hypertension. So portal hypertension itself causes splenomegaly. Splenomegaly causes sequestration of platelets. So again, it's this is part of the reason why thrombocytopenia forms part of the scoring system for patients having liver transplants and liver dysfunction. Liver dysfunction also causes low-grade DIC. So patients with liver dysfunction, they have this unusual equilibrium of hemostasis. So patients may be thrombocytopenic, but they can also be prothrombotic as well. So there's an element of consumption there, and they become quite challenging. And many of you may have seen the cases where patients will have a low platelet count but develop a new portal vein thrombosis, for example. And then you're left with this dilemma of, do you anticoagulate them, but then they have varices, for example. So they are a challenging group of patients. Increased risk of sepsis. So patients with liver disease are more prone to fungal infection, they're more prone to bacterial infection, spontaneous bacterial peritonitis being an example. And sepsis itself, as we've mentioned before, is a very common cause of thrombocytopenia. Poor nutrition. So patients with liver disease tend to become malnourished. They develop sarcopenia, muscle wasting. Some of them can have self-neglect. It depends on the etiology of it. But B12 and folate deficiency are not uncommon, particularly folate deficiency as well. Alcohol is a common cause of liver disease, particularly in the UK. And alcohol actually has a direct toxic effect on the bone marrow. So patients who are heavy alcohol users, you will see them developing things like macrocytosis and thrombocytopenia. And with cessation, you do see improvement, which is not related to the fact that their liver disease has got better, but it's to do with the fact that the direct toxicity has reduced. Again, patients, particularly alcoholic liver disease, tend to have seizures and fits, and several of these patients are often on anti-seizure medication. And these are well-known culprits for thrombocytopenia, particularly some drugs like valproic acid or carbamazepine, perhaps used less commonly nowadays, but these are things that are well-known culprits of this. Hepatitis virus is, again, well worth mentioning and well worth looking for. In fact, any patient with thrombocytopenia, I just screen them for hepatitis for a couple of reasons, but one for liver disease, but hepatitis B and hepatitis C actually directly cause thrombocytopenia themselves. And you don't, as well as HIV as well, but you don't want to really miss these treatable, reversible causes of thrombocytopenia. And then I've put kind of a catch-all plus the hematological causes. So just because you have liver disease does not mean that you cannot have ITP, TTP, or myelodysplastic syndrome. So if you're kind of running out of ideas, you can always pull these ones out of the bag and just say just because you have liver disease doesn't mean that you can get the other. But these patients have typically in severe liver disease, the platelet count is of the order of 40 to 80, and it can go lower than that. But quite often my liver colleagues will say to me, this does not look like liver disease, and that's often in the patients who have really, really marked isolated thrombocytopenia. So moving on from general causes, this is a specific hematological cause. So a patient presents with petechiae and epistaxis, and those of you who have seen this is a kind of typical petechiae that you see usually on the distal limbs, so usually distal forearm and on the legs. Particularly if you are measuring someone's blood pressure, after you measure the blood pressure, their arm distal to the sphygmomanometer, you will see petechiae appearing. And when you see people with this, it's always important to examine their oral mucosa as well, because quite often these patients will have multiple blood blisters, so-called wet purpura in their mouth. And that is considered an increased risk factor for intracranial bleeding. Now that's anecdotal, but it's certainly considered whenever these patients present. So when you see a patient with this, what's your differential diagnosis when you see someone who's abrupt presentation, very fatigued, they've got this petechial rash, epistaxis, I've said no features of sepsis, but obviously sepsis is one of the things that you can think of, and they're otherwise fit and well, they're walking around. Thank you. So TTP, any other causes or thoughts about this? Yeah, ITP. So TTP, ITP, both potential causes. If you're wondering why I'm looking to the side, it's because I've got two screens, so I'm keeping my eye on the chat. And yeah, I guess when you kind of see a picture like this, so yes, absolutely, AML and ALL definitely need to think about that as well. So for patients who present abruptly with this, you know that they're going to have low platelet count, aplastic anemia. Yes, mentioning drug history as well. So in this case, this is acute immune thrombocytopenia purpura, or ITP. It usually presents with an isolated single digit in platelet count. So when you see these patients, they have a normal full blood count, and they've got a platelet count of 2 or 3, certainly less than 20 if they've got that type of clinical picture. Now, I know in the first case I said, repeat it, but the clinical picture here is obviously ITP. You don't need to repeat it. So when you have a patient with this kind of picture, what clinical associations do you look for in a patient with single digit platelets, clinically well? So we're not thinking TTP, because TTP usually has anemia with it and features of hemolysis. What other associations would you look for in a patient who has this presentation? Let's give people a couple of minutes to have a think. I did mention one of them earlier, something that I always screen for in patients. And Batul's mentioned drug history. Yeah. Yeah, viral screen, absolutely. Autoimmune diseases, absolutely, absolutely. CLL, viral infection, yes, yeah, absolutely. Yeah, so Dr. Zeki said ITP is a diagnosis of exclusion. You're correct. It's a diagnosis of exclusion, but there's primary ITP, which is essentially just isolated ITP, and there's secondary ITP. So secondary ITP will have an underlying driver, whereas primary ITP is essentially just an autoimmune condition. Nutritional state is important. H. pylori is important as well. So the question about just mentioning about diagnosis of exclusion, if a patient comes to hospital previously well and they've got a platelet count of 2 or 3, it is almost always going to be ITP. There's very few things that will present acutely like that. So the associations I've just got here: connective tissue diseases. I've got a patient who presented with Sjogren syndrome, known Sjogren syndrome, and then they developed ITP acutely. Again, patients with systemic lupus erythematosus, they can easily develop ITP as a secondary phenomenon as well. And lymphoproliferative disorders, CLL is well known, well established. Hodgkin's can cause it as well. And the thing about these conditions is that they can be asynchronous with the ITP. So they could either pre-exist ITP, they could present at the same time as ITP, or they may develop them subsequently to it. And again, I've seen patients with Hodgkin lymphoma who have gone into remission and then develop ITP several years later. I've seen patients, again, who develop ITP and then years later develop lymphoma. So you do have to look at these patients and monitor them as well. Bloodborne viruses, so HIV, Hep B, and Hep C. Well, Hep B and Hep C definitely can cause ITP. HIV can cause an ITP-like picture that resolves with highly active antiretroviral therapy. Medications, there are several medications that are associated with it. Penicillins can be an example, for example. And then one of the positive links with many of these patients is post-viral. So patients often will have a preceding viral illness, or they may have had a vaccination and then post-vaccination, and it's to do with the fact that the immune system has been stimulated. Just to mention again with medications, we've had there's a medication. Oh, sorry. There's a medication called Lemtrada, which is used in the treatment of multiple sclerosis, and we have several cases of ITP induced directly by that condition. So there are associations with medications beforehand as well. So what do you do when you come across a patient with this type of platelet count? What would you do? Any thoughts on first-line treatment? Yeah, so someone's mentioned IV immunoglobulin and steroids as well. Yeah, absolutely. So obviously, stabilizing the patient, making sure that they're not that they're not having a life-threatening hemorrhage. You may need to transfuse and cross-match. Platelet transfusions, people say platelet transfusions don't work in ITP. They actually do have some benefit. So if you've got someone who has a life-threatening bleed, I would still transfuse them platelets if you can. But essentially, still worldwide, the first line is steroids. And there's two options currently. You can either use pulse dexamethasone, which is a mega dose of dexamethasone, 20 to 40 milligrams for 4 days, and then repeat it at 2 weeks if there's no response. Or you can use prednisolone 1 milligram per kilogram, and then you taper that over 6 weeks. It's a significant steroid dose, so you do have to give them supportive medication, both in terms of PPI, and you need to consider bone protection, particularly in patients who are at higher risk, because this is enough to cause osteoporosis in patients who are at risk for it, and potentially adrenal suppression as well. And Dr. Youssef, of course, mentions monitoring for diabetes, which is important. You can't just give this patient high dose steroids and send them home, and they'll come back in with blood sugars and they're unrecordably high, for example. Tranexamic acid is a very useful drug in ITP, and it does help. You can use it. We give a dose of 1 gram 3 times a day. You can give it orally or IV, but usually orally is fine. The main reason I've just mentioned, unless they have hematuria, is that tranexamic acid can cause clot retention if people have visible hematuria. So make sure exclude that. But generally speaking, it can help with symptoms such as epistaxis, can help with the general oromucosal bleeding as well. And then if you need, yes, we'll get on to it. So Dr. Zeki's mentioned splenectomy and stem cell transplant. IVIG is a good short-term treatment as well. It's rapid, it works quite well, but the response is usually transient for this. So the other options, so Dr. Zeki's mentioned splenectomy. Stem cell transplant for ITP, I don't think that's a standard indication for it, and certainly we have many treatments that we would use before that. Rituximab, splenectomy, yes. So anti-B cell therapy. So chemotherapy, we rarely use in the UK now, but in refractory cases, sometimes people use things like vincristine as a single dose, or multiple doses, should I say. So rituximab, but rituximab would probably come above that. And then there's now a very expensive alternative that we tend to use in the UK for chronic ITP. Treat underlying cause, absolutely. That's that. So if you've got an underlying connective tissue disease or an underlying viral disease, that should be managed, and often you will get improvements in the platelet count for that as well. So rituximab, well established. We use that. Honestly, we use rituximab for so much, it's quite hard to keep a track of what indications we have for it. It's referred to as vitamin R now. You can use immunosuppression, so you can use cyclosporin, mycophenolate, azathioprine. These drugs all have similar efficacy, but it's mainly for their steroid-sparing effect. So if you give them the course of steroids, and then after you finish the steroids, if their platelets fall again, there's no point in giving these patients repeated courses of steroids, because we all know long-term steroids are bad. And so you can potentially use one of these medications alongside the minimum acceptable dose of steroids. If you have access to rituximab is an effective treatment. And splenectomy, so in the UK, splenectomy is only used very rarely now in ITP. There's two things to be wary of with splenectomy. One is that sometimes the sequestration and the destruction of platelets happens in the liver. And so you do a splenectomy and you don't get any benefits, and you only get morbidity and mortality from it. Secondly, it's a high-risk procedure, particularly in patients who are thrombocytopenic and have a hemorrhagic tendency. Having said that, in the patients who are very refractory in the UK, we still sometimes do it, but it is very rare. And then the current drugs that we use quite often now in longer-term control of ITP are the thrombopoietin receptor agonists, or TPORAs. Of which the three that are licensed in the UK are eltrombopag, avatrombopag, which are oral tablets, and romiplastim or romiplastim, which are subcutaneous injections. These treatments are basically used as long-term treatment of ITP. They're very expensive, but they are very efficacious. And beyond this, there are more complicated and clinical trials. So we use things like BTK inhibitors, which are more used in lymphoma, for example. But you can see that some of the treatments kind of cross this boundary between malignant hematology or lymphomas and autoimmune hematology. So acute and chronic ITP. I mean, acute ITP usually is quite easy to diagnose. It's usually, a patient, child even comes in low platelets. Everything else looks fine. They look fine. They're walking around. They're just hemorrhagic, and the response to steroids is almost a diagnostic test. So if you respond to steroids initially, it's not going to be another cause of thrombocytopenia. Chronic ITP is trickier. So these are patients who present with platelet counts in the 40s or 50s, otherwise asymptomatic, other than possibly fatigue, not really hemorrhagic. And people say, why does this patient have thrombocytopenia? And so these are patients who you have to try very hard to look for secondary causes. The blood film is useful in these patients. So an abnormal film, which may show things like immature cells or evidence of CLL, for example, or may even show congenital features. So patients have giant platelets, or patients who have inclusions within their neutrophils point towards a hereditary thrombocytopenia. Splenomegaly, if you've got splenomegaly, it's not ITP. Patients with splenomegaly have a different cause that's causing the thrombocytopenia. And of course, review their medications, review their B12, check their B12 and folate. So I've just put a kind of a line on this, and I just say this because this is it's not a super common error, but it's something that we see, and I have made this mistake in the past. You have to beware of the patient who's been given a label of chronic ITP because they may have a congenital thrombocytopenia. So it's important to ask about family history. It's important to try and get a timeline for when this was first discovered and how it was discovered. Or myelodysplastic syndrome. So myelodysplastic syndrome is an acquired bone marrow failure syndrome, usually presents in pancytopenia, but rarely can present with isolated thrombocytopenia. And the hint that it could be myelodysplastic syndrome is usually it's an older patient over the age of 60, and usually you give them steroids and nothing happens, and then you do a bone marrow and then you find the changes of myelodysplastic syndrome. We don't routinely do bone marrows in patients with ITP unless there's something suspicious that there's something else that's going on. So I've just put, again, a caveat: consider a bone marrow biopsy in older patients or those that do not respond to steroids as well. Moving on to a slightly different type of case. So this is the critically unwell patient. So it's a 49-year-old patient. They have type 2 diabetes. They're in hospital and they have high fevers and confusion. They've got blood cultures and they've grown Streptococcus pneumoniae rapidly. The patient is hypotensive and they're refractory to intravenous fluids, and they're transferred to the critical care unit. They're having vasopressor support. So in this scenario, what would you anticipate would happen to this patient's platelet count? And what supportive investigations would you consider when looking after this patient? Yeah, good. So Dr. Yusuf mentions reactive thrombocytosis or thrombocytopenia, which is one of the key things to say. Yes, absolutely. Septic shock, yes. DIC consumption, yes. So everyone's recognizing that you're recognizing this. Any investigations that you'd consider to help manage this patient? And I guess the question I'm asking is, how do you diagnose DIC? Yeah, so a blood film will help. And blood films will show things like schistocytes and will confirm thrombocytopenia as well. Sometimes it will show left shift and neutrophil hypergranulation, which suggests infections. Coagulation tests, yes. So what would you do in the coagulation test, and what would you anticipate? Because in some hospitals, when you ask for that, you just get an INR. So PT and APTT, any more? Yes, yeah, PT, APTT, fibrinogen, and D-dimer, absolutely. Yeah, and a full blood count. So this is disseminated intravascular coagulation. And the typical picture that you see in this is in the early phases, you actually get thrombocytosis. So you actually see the platelet count coming up. And then over time, as the clinical process becomes more severe, you then start seeing the platelet count coming down. There's the ISTH, or the International Society of Thrombosis and Hemostasis, have a DIC score for established DIC. And essentially, these are the tests that you look at. So your fibrin degradation products with D-dimer, platelet count, prothrombin and fibrinogen. And usually what the sequence that happens is platelet count first goes up. The D-dimer is actually the first well, platelet count goes up and D-dimer goes up. So the D-dimer is the earliest sign of the DIC. The problem with the D-dimer, as many of you know, is that it's a very non-specific test and goes up in almost anything. You know, it goes up in cancer, goes up in sepsis, goes up in autoimmune disease. But it's very sensitive to DIC particularly. So usually you see the D-dimer going up. The platelet count then starts going down. You then start seeing the prothrombin time prolonging, and then the fibrinogen starts going down. So how do you manage? Yes, D-dimer, absolutely. And D-dimer is probably one of the most misused tests in emergency departments and medicine, but also in some hematology clinics as well. So it's good for excluding the need for a scan, but it's not good for saying someone needs a CTPA. And I'm sure all of you have been through a ward round and seen that the D-dimer is positive, and then had this quandary of, oh, now do I need to do a CTPA, or do I need to rule out a PE? So how would you manage this patient? So this patient's platelet count is falling. They're hemorrhagic. Yeah. 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 It's good. Good. So I'm glad people are saying treat the underlying condition, empirical antibiotics, fluid intravenously. Absolutely. So the key to treating DIC is managing the underlying cause. Treat the underlying cause, and the DIC will resolve. Dr. Zeki's put this very pertinent point. Management depends on whether they're bleeding or having thrombosis. So DIC can, it is a prothrombotic state. These patients can have arterial and venous thrombosis as well. And there's been long-standing debates of, should you anticoagulate these patients? Should you avoid anticoagulation? And it is challenging. And this is usually where you tend to, there are guidelines, ISTH have guidelines. So number one is treat the underlying condition. Most patients, unless they're very hemorrhagic, I would tend to give them prophylactic low molecular weight heparin, because these patients are critically unwell, they're immobile, they're sitting ducks for DVT and PE. Having said that, if they're bleeding, you can't, you'll have to hold off that. Although some people would argue that you can still give low dose low molecular weight heparin. When it comes to the treating the patient, there is some discussion and there's some room for replacing platelets, replacing fibrinogen, and replacing clotting factors. Now, historically, people used to treat the numbers. So they'd say you keep the platelet count above X, keep the prothrombin time less than 1.5, keep the fibrinogen above 1. And there's been a bit of a move away from that. And actually, it's more to do with how they're presenting or what you're going to do with the patient. So if the patient's having an invasive procedure, like an ERCP, for example, if they've got an impacted gallstone or something like this, then it is reasonable to try and bring their platelet count up to a target level, usually above 50, and to give them fibrinogen concentrates to try and bring the fibrinogen above 1, and potentially to correct their prothrombin time with FFP. If they're hemorrhagic, so if you're seeing the patient who is bleeding, out of their cannula sites, out of their central line sites, those are patients where you would actually give them some treatment to try and normalize their coagulation factors to support them while you're treating the DIC. But generally speaking, if they're not bleeding and you're not doing an invasive procedure, you tend to monitor them and tend to watch them. So Dr. Yusuf's asked, what would you consider as a safe platelet and INR in those patients with DIC, secondary sepsis for VTE prophylaxis? So it will depend on the clinical picture. If the patient's not hemorrhagic, then you can give them, so usually most guidelines say less than 75. You could, I would speak to your local service about what they would recommend. But if someone's high risk for thrombosis, then I would be willing to give them low dose down to platelet counts of 30 to 50 actually. unless they're hemorrhagic. But yeah, DIC is one of those conditions where it's very difficult to be an absolute. This is when you should do this. This is when you should do that, because it's a very dynamic and evolving situation. So I'm going to move on to our final case, and this is just a classic one. So it's one that's not to be missed. So 31-year-old patient, and they presents with mild epistaxis. They come to the ED. They're ambulant and they're convalescent, but they do have a fever. They're pale and they have multiple bruises, and they have a full blood count. And as part of that full blood count, it looks like this. What's going on, and what are you going to do? What does the blood film show actually as well? I try not to show too many blood films in my talks because I know they can be quite challenging. So we have a couple of suggestions. Any more, or any findings that you'd see in this film that you could describe? I'll say that there's a few abnormalities. Yeah, schistocytes and thrombocytes. Yeah, absolutely. So the first thing is these schistocytes. You see the red cells? These are fragments. So normal red cells have central pallor. And what you're seeing here is there's multiple schistocytes, multiple fragments per high-powered field. As well as that, you're seeing spherocytes. So there's no central pallor. And the spherocytes basically are there because essentially the red cells are being sheared and you're getting these small, dense red cells essentially. And the other thing is, what are you not seeing? You're not seeing any platelets. So this patient has thrombocytopenia. So you've got fragments, thrombocytopenia, and the combination of that is, yes, a microangiopathic hemolytic anemia. And the story that I've given is one of TTP. And this is one of the things that will basically wake up your hematologist in the middle of the night. If a blood film comes and someone at the laboratory phone you and say, we think there's a TTP, that's not something they say, I'll leave it till the morning. You have to come in, you have to deal with it there and then. And it's one of these diagnoses that often perplexes people, because you come into, it's happened to me more than once. I go into the emergency department, or my registrar goes into the emergency department, and we say, this patient's got TTP, we need to take them to ITU. And they say, what, this patient who's sitting there talking to us? And the problem with TTP is that it can very rapidly escalate into a condition where you get sudden cardiac death, you can get neurological dysfunction, coma. And if you've got someone who's ambulant and walking around, that's the perfect time to get them. But it's not something that you can sit on. And in fact, UK guidelines and I think international guidelines suggest that these patients should start receiving definitive treatment really within 6 hours of arrival in the hospital. So thrombotic microangiopathy, we've got a few, here are the kind of differential diagnoses we get it. So TTP, hemolytic uremic syndrome is a differential with that, usually associated with renal failure and Shigella toxin or a prodromal history of diarrhea with it. Blood film looks identical to TTP. So the difference between these two entities initially is clinically in your assessment. Catastrophic antiphospholipid syndrome is a rarity, but you can see it in patients with, and so when you're suspecting, you should test for all of these. DIC can give a similar blood film appearance, and then malignant hypertension is another one that can as well. So just a little bit about TTP. So what is it? There's two forms of it. There's an autoimmune form, and which can be drug induced, by the way, or there's a congenital form. The congenital form obviously presents in childhood, and is due to loss of this enzyme, Adams TS13. So what happens in TTP is that you get an autoantibody to this enzyme, Adams TS13. What does this enzyme do? Well, in normal health, you produce von Willebrand factor from the endothelium, and it's in the blood vessels itself. And von Willebrand factor is normally in large multimers, but those large multimers are highly active. And Adams TS13 essentially cleaves that into smaller multimers, and that helps manage hemostatic balance. When Adams TS13 is depleted by an autoantibody, you have these ultra-large multimers of von Willebrand factor in the blood, and these have a domain that interact with glycoprotein 1b on the surface of the platelet. So these von Willebrand factor molecules interact with the platelets and activate them. The platelets then essentially degranulate and they get consumed. That's why you get thrombocytopenia. And you get multiple thromboses throughout small blood vessels. And what then happens is the red cells pass through these thrombin webs, and that's why you get the fragmentation. So these microthrombi affect typically the coronary arteries, and that's why these patients, or actually the myocardium. So even though they've got normal coronary arteries, they can get myocardial ischemia and can cause neurological features. So they can have seizures or strokes even as well, or dropping in their GCS. So patients with TTP, as part of your workup, what you will do is you would check their troponin. You would also look for hemolysis. So they tend to have a low hemoglobin, low haptoglobin, high LDH, and high bilirubin, tend to be jaundiced as well. But if you catch this well, if you catch this early, they have an excellent survival. And the standard of care at the moment, presently, is plasma exchange. And what you're doing with plasma exchange is you're removing the autoantibody and you're replacing the Adams TS13. And by doing that, you normalize their platelet count usually within 2 or 3 days. And the plasma exchange usually continues for a few days. At the same time, you give them methylpred to try and suppress the antibody from being produced. And we also, in the UK, we give rituximab. We have a very low threshold for giving rituximab. And essentially, the current indication is if there's any neurological or cardiac features, give rituximab. But essentially, all the patient has to say is they have a headache and we will give it. There's now a novel treatment. Good question about, is this lifelong? The management, so I'll come to that in a second. The other recent treatment, which is become available for TTP, incredibly expensive as you can imagine, is a monoclonal, well, it's a nanobody called caplacizumab. And what that does is it blocks the interaction between glycoprotein 1b on the platelet and the von Willebrand factor. And this can put people in remission as well. Now, plasma exchange is not an easy thing to give. And in fact, within the UK, we have a centralized system where there are multiple TTP centers and patients from throughout a big area. So population. So in our hospital, we manage a population of 6 million for this condition. This has an incidence of 1 in 1 in a million. So you can't have plasma exchange available at every single hospital. So we have 24-hour plasma exchange available here. But the key thing is being able to diagnose it, recognize it, and then speak to the center. But potentially with this treatment is given as subcutaneous injections. You might be able to treat people locally. The question about, is this treatment lifelong? So no. So the initial treatment, the plasma exchange is a short-term treatment, the steroid is a short treatment, and the rituximab is a short-term treatment. Patients are typically in hospital for 1 to 2 weeks. Once they're stabilized, you can then manage them as an outpatient. But the subsequent management is essentially monitoring their Adams TS13 levels. And the idea being that you will, once they're stable, once they're in remission, we monitor them every 3 to 6 months down the line. And if the idea is that you want to try and catch Adams TS13 before it drops to a critical level, basically. And you can retreat with rituximab, for example, or retreat with steroids. What drugs cause this condition? One of the classic ones is quinine. Quinine as well is a drug that has been linked to this. Some of the HIV drugs have been linked to it as well, although rarely. But yeah, it's a rare condition. It's a devastating condition. You can see it's also postpartum, as with many autoimmune conditions as well. But the key thing about this is recognizing it and treating it early, or making sure that you've got the ability to treat it early as well. So I'm going to finish at this point. There are a few other things that I've not gone into much detail about at the moment. So pregnancy, just because you could give a whole lecture on just pregnancy and thrombocytopenia. The commonest cause is gestational thrombocytopenia. The management of that is just expectant management. But these patients can also develop complications later in pregnancy, such as HELP syndrome or preeclampsia, which can also cause, or DIC because of abruption. So pregnancy has a whole host of things. And obviously the management of pregnancy is very, very subspecialist. Myelodysplastic syndrome is another condition which is an acquired condition. I specialize in that particularly. And you need to think about it in patients who are older but also younger, and patients who fail to respond to treatments for thrombocytopenia. Aplastic anemia is associated with a pancytopenia, but another consideration diagnosed with a bone marrow biopsy. And then there are the familial thrombocytopenias as well. So just as a general overall approach, you have to think about the clinical context. Is this an outpatient? Is this an emergency? Think of the chronicity of the thrombocytopenia and think of the severity of it. Always review their medications. Do look for risk factors for liver disease and do examine them for splenomegaly, because that gives you a big hint as to what's going on. Look at the trend of the full blood count if it's possible. And if you can, always request a blood film, because in thrombocytopenia, the blood film is one of the crucial things that can help you diagnose what's going on. Consider if it's an isolated thrombocytopenia or if there are other cytopenias with it. And I'll just say, as a general thing, rule out straightforward causes. Make sure you check the B12 and folate. Those are easy things to treat and easy things to diagnose and manage. Don't miss HIV, Hep B, and C, because these have important implications for the patient. And quite often, patients will be referred to hematology. And if they don't do this, then they can present much later with worse complications. And then consider your ancillary tests depending on your findings. So consider an autoantibody screen if someone has features of Raynaud's, for example, or if they have photosensitivity or ulcers, for example. Consider a hemolysis screen if a patient's anemic, if you're thinking of an emergency or if you're thinking of TTP, for example. And again, I tend to request an abdominal ultrasound for quite a few of my patients who present with thrombocytopenia, mainly because the liver disease can be quite occult, and it could be the earliest sign of that as well. I didn't mention here as well, but you can also check your clotting test if you're suspicious of DIC. So thanks very much for listening on a Saturday night. If you have any questions, I'm happy to have an open discussion.
Thank you so much, dear doctor. What a wonderful lecture. I will start the questions panel here because I facing it on daily basis, as I mentioned before. The complex issues between thrombocytopenia and oncology. We have in our words a lot of patients, and even today we have multiple ones. In a patient with a known case of solid tumors and isolated thrombocytopenia, what are the features that would raise a suspicion of bone marrow infiltration in them?
Yeah, absolutely. So I guess there's a few points with that. So I guess the first thing is the type of tumor. So there are certain tumors that we know have a predilection for metastasizing to the bone marrow. So if you know that the patient's got metastatic disease, or you know they have a tumor that has a high risk for this, then those things will point you in that direction. Classically, those patients will also have an abnormality on the blood film called a leukoerythroblastic blood film. So within the blood film, you would see things like nucleated red cells, teardrop poikilocytes, and left shift of the myeloid cells. And when you see that, that's quite suspicious for bone marrow involvement. And under those circumstances, they should be evaluated with further bone marrow. The other thing to consider as well in the solid cancer patients is there is a potential risk of secondary myelodysplastic syndrome, and we're seeing more of this in patients who have more people are treated for cancer, more people are surviving for longer, which is good news. But there is a condition called therapy-related myeloid neoplasm, and any exposure to radiotherapy or chemotherapy, usually it's a late complication, but it can happen in treatment, particularly if the patient has a susceptibility to it, and they may develop myelodysplastic syndrome, which really complicates your treatment because delivering chemotherapy in someone who already has a different hematological neoplasm becomes very challenging. Actually, we have MDTs where we have oncologists and hematologists, and we have to decide, which of these cancers are the ones that is the more immediately life-threatening, and which is the one that we need to treat now, or is there a case of is treatment actually going to be deliverable in some cases?
Thank you so much, dear doctor. Coming to the next and last question for me, that we may use the thrombopoietin receptor agonist like romoblastin. So what are the considerations in our oncology patient, and when we use it in the right way? Because I see we use it maybe actually a lot of maybe mispractice in it. So what are your um, evaluation for it, and how we can use it in the proper way?
Yeah, so this is it's a great question, and the issue with thrombopoietin in is it's licensed for ITP, so we know it works in ITP, and that's a very specific indication for it. It's also licensed in liver disease when you're trying to do a procedure. So patients with liver disease, you can use eltrombopag as a bridge to get a platelet count up so that you can safely do the procedure. And some people kind of extend that to procedures including chemotherapy. It can be used in myelodysplastic syndrome. So in myelodysplastic syndrome, there is evidence that you can use ITP and that can reduce platelet transfusions. I guess the core in oncology, the core question is what is your threshold for chemotherapy? Because quite often you find the threshold for managing thrombocytopenia is somewhat arbitrary. So for example, in some regimens they say you can omit the cycle or dose reduce if the platelet count is below 50. Whereas in hematology, because I guess probably just by nature of our job, if someone's got lymphoma, for example, we're not going to dose reduce their R-CHOP, with each cycle if they become thrombocytopenic. We'll just support it. So use of TPO agonists in oncology it's going to be off license. If you're using it to try and keep their platelet count above, I'd say above 30 is probably justifiable because I think you don't want to give them you don't want to hammer their chemotherapy too much so that they drop down to below 20 and they're bleeding. But it's a very tricky and murky area. And the other thing is that you want to make sure that you're not missing another diagnosis by the fact that you're using the TPO agonists. They're generally safe drugs. They're safe drugs. There's a theoretical risk of thrombosis, which is increased with the drugs, but it's not a huge increase in risk. And eltrombopag particularly can affect your liver function, but generally speaking, I think this is an area which is clinical trials would be really quite valuable in answering the question.
Thank you so much, dear doctor. Crystal clear. So I invite all of my dear participants to write if they have any questions that they can raise the hand icon button and you can directly talk to Dr. Haida. And I think we have a question at the chat box, dear doctor.
Yes. So I can see two questions. So when do you think about congenital thrombocytopenia? So congenital thrombocytopenia, I mean, what I would say is when you evaluate the patient, if there's a family history, then obviously you think of it at that time. If they present at a young age, you consider it at that time as well. If the platelet count is essentially just stable and not changing at all, then that's another time that you'd consider it. And also you do a blood film because quite often the cause of congenital thrombocytopenia, there are abnormalities on the blood film. It is and also patients who don't respond to steroids, for example. It's rare. Congenital thrombocytopenia is a rare condition, but I guess the main thing is to not forget it rather than to look for it actively in every patient. And in ITP, when is my practice to order a bone marrow? So I tend to do a bone marrow in patients who don't respond to steroids. So in my first line, I'd give them steroids, and if they respond to it, then I think that's enough to call it a diagnostic test for ITP. If they don't respond to steroids, that's when I think, is there something else that's going on? Is it myelodysplastic syndrome? Patients who are older, I don't routinely do bone marrows if it's a clear diagnosis of ITP, but if there are other features, so if the blood film looks abnormal or if they have splenomegaly or something like that, then those are the patients who I would do a bone marrow on. Hope that answers the question. Okay. Any more questions?
So do you have any more questions for Dr. Haidar? Okay, so thank you so much, dear doctor. So ladies and okay, specific ratio. Okay, we have a question from Dr. Mustafa Zeki. Is there a specific ratio for platelet to RBC on a blood film?
Um, so there is. It depends on what objective you're looking at. Um, everyone has a slightly different way of looking at it. So some people will cut the objective into quadrants, and if you count 20 platelets to the red blood cells, and that usually counts as a normal platelet count. You can actually use an optical grid for counting the platelets and then calculating up that way. But it's very much in my practice, it's very much just by feel. So I look at it and I'm just like, that looks thrombocytopenic, or that looks like it's thrombocytosis. Okay, thank you, everyone.
Thank you so much, dear doctor. So we have a beautiful journey today through a delicate world of a bleeding disorder. A field that reminds us that medicine is not merely about a fixing number, but about understanding the intricate symphony that sustains life, from inherited deficiencies to acquired dysfunctions. We were reminded that the drop of blood within holds within it universe of complexity. Thank you so much, dear doctor. As we bring to enlightening this session, I extend my deepest gratitude to you, dear Dr. Haida. I offer my sincere thanks for your insightful and have my deepened. You have not only deepened our understanding, but have also inspired us to approach this condition with a great precision, compassion, and curiosity. Your presence here has been a gift to our entire network. Thank you so much. And I extend my thanks to Dr. Zainab Akram, who made this beautiful session possible. Thank you so much for your great effort and time, dear doctor. And to all of you, dear participants, thank you so much for your presence and passion here. So as a finally, so stay connected to our RCP London Reiki Network for upcoming events and continued learning opportunity. On behalf of scientific committee, I wish you a restful evening and continued success in your professional journey. Until we meet again, stay safe, stay curious, and stay compassionate. Thank you so much. Thank you so much, dear doctor. I hope we will meet again
Inshallah.
in upcoming events, inshallah. Thank you so much.
Assalamu.